Today, we would like Dr. Beena to tell us more about mucopolysaccharidosis.
Mucopolysaccharidosis is also called as shortly MPS. It's a metabolic disorder. It comes under the group called lysosomal storage disorders. So our body has a lot of enzymes to break down complex substances. So mucopolysaccharidosis is also because of a defect in a gene which breaks down long sugars called mucopolysaccharides or glycosaminoglycans. So normally these glycosaminoglycans, also called as GAGs, they undergo a lot of steps to be broken down into simpler substances. In children with MPS, certain enzymes are deficient. So what happens is the body is not able to break down the glycosaminoglycans. They get accumulated in special structures inside the body where they're supposed to be broken down. These are called lysosomes. They accumulate in the lysosomes. The lysosomes get swollen up. These block a lot of important organs like the liver, spleen, the heart, and more specifically, the bones, especially in children with mucopolysaccharidosis or MPS. Yes, mucosaccharidosis type 1 or MPS type 1 is a little rare disorder. It can be seen in 1 lakh children. And there are three different types in MPS type 1. So as I told you before, the GAGs get accumulated in different parts of the body. And here it involves the eye, the face, the liver and spleen, and the bones especially. So because of these, the children can have short stature, they can have abnormalities in their appearance, involvement of the heart, brain, etc. because of the depositions of GAGs. So as I told you here, there is a deficiency of an enzyme which breaks down GAGs. In MPS type 1, the name of the enzyme is called alpha iduronidase. So deficiency of this enzyme is responsible for MPS 1, and depending on how severe the enzyme deficiency is, it can be mild, it can be moderate or severe. The severe type we call as Hurler. So here the children can have intellectual impairment, developmental delay, severe skeletal problems. All this can occur in MPS type 1 Hurler. In between, the moderate type is called Hurler-She, and the mildest is the attenuated type, which is She. Here, the children present only with skeletal abnormalities, and that too a little later in life. So, we have three different types depending on the amount of enzyme deficiency they have. More deficient, more severe is the disorder. Less deficient, milder is the disorder. So, it is a spectrum comprising of three different types. Yes. So here the main problem is deposition of GAGs in different parts of the body. So to start with, the babies are normal when they are born. So the GAGs accumulate over time and parents notice that the child's face appears a little different. We call it as coarse facial appearance, where the eyes are little wide apart, the nose appears depressed, the lips appear larger and thick, the mouth is open. The child can have protrusion of the chest, which is called as chest deformity. They can have spinal deformity, which we call as gibbous. So usually these are the signs which the parents first notice and bring to the care of the physician. Some of the children can have corneal opacity. The clear part of the eye, that is the lens, the cornea, gets clouded, and these children present with what is called corneal opacity. So these are some of the symptoms which the parents first notice and bring to the care of the physician. Yes, to first have a basic idea about the disease, we do a detailed clinical examination. As I told you, note down for features of coarse facial features, look for liver and spleen enlargement, any cardiac abnormalities. Then we take X-rays where we have very specific findings that are characteristic of mucopolysaccharidosis, and that is called multiplex dysostosis. So having all these on X-ray also tells us, okay, this child is probably suffering from mucopolysaccharidosis. Then we order a test called urine examination for GAGs or glycosaminoglycans. So in children with MPS, because there is extra accumulation of GAGs, they excrete a lot of it into the urine, and identifying higher amounts of GAGs will help us also to think of MPS as our primary diagnosis. To confirm this, however, we need to look at the levels of the enzyme. So as I said before, here the enzyme is alpha iduronidase. So finding a deficiency of this enzyme tells us that this child has MPS 1. And genetic confirmation will help us in doubly confirming the diagnosis. Yes, so there are totally 7 different types of MPS, many of which closely resemble MPS type 1. And in this group, similar to MPS, there is another group called eye cell disease, which also can have coarse facial features, short stature, exactly like how these children present. So these would be some of the differentials, and our further testing will help us to narrow down the diagnosis. So yes, the survival would depend on the amount of enzyme that is deficient. So less deficiency would mean a better outcome. More deficient enzyme deficiency would mean a severe disorder and shorter outcome. So the other complications that we will be touching upon later also determines the quality of life. So because the gaps get deposited in various other organs, the overall survival is lesser than that of other children. But with good care, we can aim to give them the best quality of life. Because gas deposition happens in almost every organ, complications can also arise, and so we need a multidisciplinary approach for these children. So it means they need to be seen by a lot of different specialists for an optimum amount of care. So the main problem here for these children would be in the bones. So they would definitely need to be seen by an orthopedician yearly or even more frequently. A neurologist and a neurosurgeon may be needed because these children can have fluid accumulation in the brain called hydrocephalus, for which shunting maybe would probably be need to be done. And same way, a more important problem here that can happen is the spinal cord. The spinal cord can get narrowed and compressed because of the accumulation of gags. So this needs to be looked at an emergency basis. And again, a neurosurgeon and an orthopedician can look into it. ENT physicians. So these children can have deposition of gags in their throat and especially the adenoids and tonsils. So they may need to be operated for that. They can, because of this blockages here, they can get fluid accumulation in the ear, which needs to be relieved frequently by a simple procedure called myringotomy. We need to take special care of the eyes, as I told you before. These children can have corneal opacity or clouding of the cornea. They can have increased pressure of the eyes. They need to be seen by an ophthalmologist because they can have corneal involvement where the cornea can be clouded. They can have increased pressure inside the eyes, which we call as glaucoma. And sometimes the retina can also undergo degenerative changes. So definitely an ophthalmologist surveillance is very important for these children. Similarly, a cardiologist, because they can have valve thickening and cardiomyopathies can be there. So cardiac involvement, cardiologist needs to oversee. A respiratory physician, especially to look for something called pulmonary function tests. So because these children can have chest deformities and spine deformities, their lungs can get severely restricted. The normal breathing in and out, the normal exchange of oxygen and carbon dioxide can be impaired. So that needs to be checked with the help of a pulmonary function test. They can have umbilical hernias, have inguinal hernias, which needs to be corrected with the help of a pediatric surgeon. Very important here is the role of an anesthetist. So these children will have short, thick necks and they can have spine abnormalities. So very careful intubation and anesthesia is necessary. So an experienced anesthetist is very, very important in this scenario. These children can have sleep apnea, where their respiration stops for some time during sleep. So that needs to be attended to at the earliest. And we will do a test called sleep study, which will pick up these episodes. And if need be, the children can be put on something called CPAP, which will help them with this particular issue. Definitely, a geneticist needs to be in the loop to explain to the family regarding the disease, the chance of recurrence, what needs to be done to prevent this disorder from recurring again in the family, and to organize all liaison with various other departments. A geneticist is necessary, a dietitian to look into the diet for these children, and a general physician to look into their vaccinations like their yearly flu vaccination, pneumococcal vaccine, so that they are protected from frequent respiratory infections. So
Thank you,
it's
doctor.
definitely a multidisciplinary and a multimodal approach that is needed for these children. Yes, definitely the family needs genetic counseling because mucopolysaccharidosis, especially type 1, is autosomal recessive in nature. So that means a child gets the disease gene from both the parents. And there is a 25% recurrence risk in every pregnancy. So ideally, the family needs to come to us before planning a pregnancy so that we can work up the affected child, whom we also call as the index child. So we will be doing an enzyme evaluation and a genetic testing to find out the exact genetic problem in that particular affected child. This can then be used to plan testing in the pregnancy. So it can be done anywhere between 11 to 13 weeks of pregnancy or after 16 weeks by a test called amniocentesis. When it is done at 11 to 13 weeks, we call it as chorionic villus sampling. So the particular mutation in the family will be specifically checked for in the CVS sample, and we can know if the fetus is affected or unaffected even by early pregnancy. So this disorder doesn't present by ultrasound, and it will present only after a few months of birth. So invasive fetal sampling by CVS or amnio would be the only way to identify the disorder. Genetic counseling is also very important so that other family members, so there could be brothers and sisters of this particular parent who might want to get married. So we can also ask them to get screened for this disorder so that we can prevent this happening further in the family and at the population in at large. So another option that these families can opt for is IVF, in vitro fertilization, with pre-implantation genetic testing. So here in the embryo, this particular genetic problem is looked for, and only the embryos that are good are actually put back into the uterus so that that future diseases can be prevented, especially for MPS type 1. And again, this is confirmed by CVS or amnio later in pregnancy. So there are definitely ways we can prevent this disorder from happening once we know the index child's mutation. So currently, we don't have a permanent cure, but yes, we do have certain modalities by which we can help them out. So one is hematopoietic stem cell transplant, or shortly called as bone marrow transplant. So this can be done in children with type 1 Hurler, that is the most severe type, but before 2 years. So it has been found that for these children, the neurocognitive delay or worsening happens mainly after 2 years of age. So if we identify them before 2 years of age, doing a bone marrow transplant will help to prevent the neurocognitive decline. So a bone marrow transplant or a hematopoietic stem cell transplant is advised for children with MPS type 1 Hurler before 2 years of age. So after 2 years, once the neurological deterioration starts, it doesn't help much. The next option that is available is enzyme replacement therapy. This is available for quite a few children here. So the advantage of enzyme replacement is that it crosses over to a lot of tissues, but it doesn't cross over the blood-brain barrier. So the brain changes cannot be reversed. So that is why Hurler, which has the severe type, we advise BMT. For the others, it's enzyme replacement therapy by an enzyme called aldurazine. So this is an artificial enzyme preparation to replace the one that is deficient in the body. It is given weekly once by an intravenous infusion. So the family has to travel to hospital. This is taken as a weekly infusion, and it does improve the overall quality of life for these children. So the liver and the spleen regress. The child's growth velocity overall improves, but again, it doesn't cross the blood-brain barrier. The heart, cardiac changes, certain changes are reversed, but certain changes are not reversed, like the thickening of the heart that will improve. But the valves, which are already damaged, cannot be undone. So certain changes persist, but many of them resolve with time, and definitely it improves the quality of life. So that is the greatest disadvantage now. So it is very, very expensive and is not freely available to all the children. Only a few children on compassionate basis get this drug. So if it is widely available, it would be very, very helpful to those children who are not eligible for a BMT. So definitely, if this is available on a free basis, it would be of great help to the children. But right,
Yeah.
currently it is not. Yes, definitely. Our government has also taken a lot of steps to help these children. So, at the national level, we have LSDSS, which is Lysosomal Storage Disorders Support Society. So, all children who come under lysosomal storage disorders are registered, and help is given to them to meet surgical expenses and for a few medicines. So, for these, definitely LSDSS does help. Now, the central government has also started centers of excellence in every state. So the children can get registered under the government approved centers of excellence and avail the treatment. So we are trying to get enzyme replacement also for these children here. We have our Center for Excellence for Rare Disorders operating at VHS. So here too, we have a support group here for children, and their cares are taken care of in a wholesome way, where we have multi-speciality people, doctors helping in with the care of these children.